I'm very glad that you joined us tonight. Thank you for giving us your time, and we have an interesting conversation planned about hospice and palliative care and end-of-life planning, long-term care planning. And this is a topic that our nurse practitioner, Heather Braucher, came up with several months ago. She's been talking about planning this evening for you. And so why don't we start with Heather and why you thought this was an important topic for tonight?
Sure. So again, like Connolly said, I really appreciate everybody being here. I know this is sometimes a little bit of an intimidating, topic discussion to have. So I guess my goal today is that we can answer any questions, kind of help people prepare as well as possible, correct any misperceptions that there might be about, end of life care, hospice and palliative care. And again, just kind of create, sort of a safety space to have some discussion and answer any questions. I guess just to give a little bit of my background. So I worked in acute care for a number of years in oncology, so worked in the hospital, and then worked in hospice care for about 7 years, both inpatient and outpatient. And most recently actually worked with formerly hospice and palliative care, and mostly served the long-term care communities with the majority of my patients having a dementia diagnosis. And I've been here with memory movement for 2 years. So, and I have the privilege of working with all three physicians right now.
And I'm Katie Cooper. I'm a social worker here at Memory and Movement. And so I end up having a number of these conversations with many of our caregivers. So I thought it'd be nice to join and contribute if I've got anything extra.
And I'm Jessica Twaddle. I'm the social work preceptor with Via Health Partners. A lot of what, my history actually, interestingly, I was an intern with Via Health Partners back in the day. Went out, I did mental health and worked with geriatrics for many years and then came back into hospice. And we do have a lot of conversations about the benefits of planning and advanced directives and working with our families and navigating through that.
And I'm Tara Connolly. I'm Vice President and Chief Growth Officer. I've been with VA Health Partners for about the last 7 years, and I have a team of folks that are out in the community helping to advocate for patients and families to get hospice care, get palliative care, and to really connect people and resources in the sort of senior geriatric community.
My name is Kyle Vaya. I've been with VA Health Partners for about a year now. I work in a lot of the assisted livings, the doctor's offices, as well as the skilled nursing facilities.
And just to kind of add to what I said earlier, I think one of the reasons I approached Melanie with this topic is I think just, from personal experiences, professional experiences, had a lot of experience, with, obviously advanced care planning going really well, not as well, and really feel strongly that people should have the opportunity to communicate their wishes, about what kind of care they would want, where they would want to receive that care, who they want to make those decisions, and also the impact on family members, having to be surrogate decision makers. And I think one of the things, being part of Memory and Movement is that we care for people at all stages of life. And we really want to be able to care for people through, the spectrum and through the course of an illness, whether that be, consult and initial diagnosis, chronic disease management, and also through end of life. So it's important that we do that piece well also.
Okay. Shall I ask questions? Is that how we should do this?
Sure.
I'll get it started and then you guys take it away, okay?
Yeah.
Can you explain to us, please, or to me, what is the difference between hospice and palliative care?
You guys want to take that one?
Sure.
Okay.
Sure, I'll take that one. So hospice care is truly end-of-life care. Medicare defines it. It's a Medicare benefit, and Medicare says it's the last 6 months of life. Now, we do end up keeping people under care longer than that, but it is for that truly end of life. Palliative care is really a much broader term that's really palliating symptoms. It's for anybody with a chronic disease. So it doesn't have to be end of life. So we get involved on the palliative care side much sooner. The other big difference is the payer source. So hospice is a Medicare benefit. So it's paid for by your Medicare Part A benefit. So that covers your hospitalizations, your skilled nursing days, and hospice. Palliative care is paid for with your Part B benefit. So just like when you come to this office, you get a Part B charge. So we do the same thing. It's like an office visit, only we do those visits at home, at skilled nursing facilities and assisted livings. And we do have some clinics as well. So that's some of the differences.
So
I think what's important also is palliative care, the patient can still seek a treatment
Yes.
or a therapy under that, as opposed to hospice.
So you still see your same doctor that you had before palliative care?
So palliative comes alongside and works with, say, Dr. Edwards, with Heather. We might work with a cardiologist if the patient has heart disease, or pulmonologist if they have COPD. So we're there to add on and be like that overarching consultant, where we're always talking about goals of care, symptom management. So really optimizing quality of life. So it's focused on that quality of life. And then as the disease progresses, looking at what are the benefits and burdens to, as you move through the disease, potential treatments. So, here's the next treatment they're going to recommend for you potentially. Here's the benefit of it. Here could be some side effects and burdens. So it may help this, but it may cause this. So really helping people make decisions. We don't make the decisions for them, but sort of walking them through what's down both of the paths, depending on which decision you make. And then helping the family all come together with that decision. So having that family conversation. So like Heather said, it's really important for you to know what your loved one wants. If your loved one has dementia, the sooner you can get palliative involved, the sooner you can have these conversations. You don't have to make those decisions for them. They're going to tell you what they want. And then it becomes your obligation to honor those decisions and follow through with them.
And I think just to kind of piggyback on that. So, again, why is it important to have these discussions? So I think it's kind of, multifactorial. So one being, obviously, like I mentioned before, I think that people should have the opportunity, to express their wishes, about what kind of care that they would want, in the event that they were not able to make those decisions. And I think also it provides some peace of mind, to have those decisions made, kind of have things in writing and document it. And I think for the family's sake, from my experience, it is much easier for the family to say, I know what their wishes are. They've been documented. I'm just advocating and honoring their wishes, as opposed to never having had those conversations and, kind of trying to guess, I think this is what they would want, but I'm not sure. So really communicating those wishes, to your family member, whoever would be making those decisions, is such a gift, because I think it really decreases the stress level and, potential guilt, for, did I make the right decision? Did I not make the right decision? And then also, I think the other reason that it's really important to have those conversations is to avoid potential conflict between, family members, decision makers, because a lot of times, there are family members, friends, a lot of people involved in the support system, and they may not always agree, on what type of care, what decisions should be made. So I think having those, kind of set ahead of time and in writing is really helpful. And also, I think just, a lot of times when we're making those decisions, it's, when there's an acute illness or a change in condition, and that's already a really stressful time for people. So I think to have to make decisions, on top of dealing with a stressful event, it's very difficult, and it's hard to make those decisions sort of in the moment.
Good question. Yeah, is this different? Palliative care, is that different from the healthcare power of attorney and the living will?
Yeah, so we'll talk about that a little bit. So as far as advanced care planning, so, and it is a little bit different, North Carolina versus South Carolina, kind of what they recognize. So a living will is a document that will communicate what type of care someone would want to pursue, but more importantly, what type of care they would not want to pursue. And, obviously that's put in writing. And so that goes into effect if somebody is permanently unconscious, terminally ill, or close to death, or they have advanced dementia or a similar condition, which would result in a substantial cognitive loss, and highly likely the condition would be reversed. In South Carolina, it's also known as a declaration for a desire for natural death. So that is kind of what a living will is. It's sort of putting your wishes in writing. so that somebody can kind of refer to that, obviously it communicates that with your decision maker, with your family, with your physicians involved with your care. And then there's healthcare power of attorney, which is designation of somebody who would make decisions on your behalf in the event that you are not able to make those decisions. And you can have both a living will and a healthcare power of attorney. And you can actually specify in the living will whether the healthcare power of attorney could, override the elections in the living will in the event that something unforeseen would occur. So those are kind of the sort of legal advance directives. They do not require an attorney to complete those forms. That can actually just be obtained online, and 2 witnesses would have to sign the forms to make them valid, and also would have to be notarized. And those can actually be obtained online a couple places. So North Carolina Secretary of State has those forms, and I think typically they're pretty inexpensive, like $5 or $10 to get those forms. Local VA office, AARP, I know has them available. National Hospice and Palliative Care Organization has links to forms. The South Carolina Bar Association, and then in South Carolina, there's something called 5 Wishes. We have a copy of that if anybody is interested in that. But it also is legally recognized as declaration for, desire or wishes end of life. And that kind of encompasses both living will and healthcare power of attorney. And the other thing too is, I know sometimes these decisions or discussions can be really difficult, especially kind of approaching, the discussion initially. And there are some tools that will help, kind of guide the conversation. So I think the 5 Wishes is a good one because it kind of talks about, what kind of care would I want, if in the event that I would be unable to make those decisions, who would I want making those decisions? How comfortable do I want to be? So that's helpful. But there are other resources, the Conversation Project. I know that that's something that Katie has mentioned before. Prepare for Your Care in My Life Choices in South Carolina. So if you need assistance, kind of having those conversations, what exactly do we need to talk about? Those are really good tools to kind of help guide those discussions.
Yeah. And so palliative care, one piece of it is that goals of care. And if folks don't already have those legal documents in place, then we can certainly help guide them in that direction. But then we also focus on symptom management. So managing the symptoms related to whatever that terminal diagnosis is. And then reinforcing the goals of care, because again, you have different family members coming in at different times. And they're like, well, no, I want mom to go to the hospital and be intubated. And so it's sort of continually reinforcing those. And then also talking about what is the next stage. Here's where we are today in the disease. What are sort of the next steps? What are you looking for? And what can you expect?
And is it documented somehow so that everybody knows what's been discussed?
So we document it in our charts whenever we're involved. And then we'll usually provide notes to, to Dr. Edwards and his group and to Heather. And then we can certainly give you those as well. But all of the forms we leave for you all, so you have everything because you need it. You need to take it if you go to the hospital. Like those forms need to be with you.
Mm-hmm. Yeah, and those, like I said, those forms really do document, kind of what the choices would be regarding care. And it does specify, kind of if there is a healthcare power of attorney, sort of what range, of what liberties, I guess, that they could take if there's an unforeseen event that would happen. The other thing that we wanted to talk about, so there are also a couple forms that are more medical forms than legal forms. One being a do not resuscitate form. And that's kind of the goldenrod, I guess, is sometimes how it's also referred to. And the difference is because I think sometimes there is confusion between, I have a living will, so I have a DNR, but they're a little bit different. Obviously, the living will being a legal form, DNR being a medical form or a medical order, actually, that has to be signed by either a physician, nurse practitioner, or physician assistant. And I think the sort of part of the differences, and correct me if you think something different, but I think in an event of an emergency, somebody probably isn't going to read through a living will. So that's really why it's really important that if somebody does not want to pursue, CPR, that they have a do not resuscitate, because it's kind of, right there available if their EMS would come to the home. It makes it very clear what the wishes would be. So that's why that's important to have in addition to a living will. And then in North Carolina, there's a form called a most form medical order for scope of treatment. And that is more specific. It talks about actually 4 different categories of care. One being desire for CPR, level of medical interventions that you would want to pursue, kind of being full interventions, limited scope of treatment, or comfort measures. It talks about desire for antibiotics, and then also desire regarding artificial hydration and nutrition. That is also a doctor or medical order that can be signed for by physician assistant or nurse practitioner. And again, I think it just makes it very clear. It's very accessible to everyone involved in the patient's care. What their desires are. A couple of things that I did want to mention about choosing a healthcare power of attorney, because I think that's important too. One, if you are going to select somebody as your healthcare power of attorney, make sure that they know that you are selecting them. Make sure that they are willing to serve in that capacity and to honor your wishes. And also make sure that they are able to serve in that capacity. So I know sometimes folks will come to our office and they've had forms that were, completed, 10 years beforehand, and it may be their spouse that's designated as their healthcare power of attorney in the event that, they should be unable to make decisions. But if that person is not cognitively able to make those decisions, just kind of keeping in mind that it might be important to update those forms. And then when you do have those forms, just making sure, again, that your physicians have a copy on file, that the person who, is going to be in charge of making those decisions, like healthcare power of attorney, they have a copy of those forms. And then also I would keep, especially the most form in the DNR, I would make sure that those are easily accessible at home, and that any caregivers that would be involved in care would know exactly where those are.
Somebody's posted a question in the chat box. Is there someplace a list of choices for end-of-life care, or maybe a checklist or something, so you sort of know you've done all that you should do and consider everything you should consider?
Like in regards to like medical choices, or as far as like having,
Maybe the person who posted the question could clarify that.
okay. Yeah, like I said, I know, the living will, the 5 wishes, those are pretty, relatively detailed as far as what kind of care somebody would want. But obviously that's why we're here too. One of the things that a good majority of our patients are eligible for is a care plan visit. I'm not sure if you guys have done those before. And that's one of the things that we do try to do, kind of to your point again, things do change, and as disease progresses or clinical condition changes, decisions change too, goals change. And so we try at least annually for our patients and families to kind of check in about the advanced directives. Our wish is still the same, have things changed, and update those if that's necessary. But certainly too, those are things that we can walk you through. This is what I have, what else do I need? What else would be, appropriate at this point? And we can certainly kind of either, guide you to those resources, help you complete, so the most form and the DNR, those are things that we can complete here in the office during a clinic visit. So either, any of the providers here would be certainly happy to go through those forms, and that can either be done for a telehealth visit too, or phone call too. So we're certainly always, available to help you guys get those things in place.
Okay, hope that answered the question from the chatter. If anyone has any additional questions, please feel free to turn off your mic and ask them, or put them in the chat box.
Can I ask another question? So palliative care is like more discreet then, right? So like hospice, I feel like it's kind of like somebody's coming all the time to check on the person. Whereas palliative care, you're coming, you're helping do an assessment, you're getting everybody on the same page about things, and then maybe you check in again after a period of time or something like that. But it's not, and this is my father-in-law we're talking about. So, we've got various caregivers coming, but this sounds like this is more sort of a consulting kind of thing.
It's much more of a consultative.
Right.
It's almost like going to see your physician. So palliative care, I would say we probably on average see our patients once a month. If somebody's relatively stable, their advanced directives are in order, they're not having any symptom issues, then we may say, hey, we'll check in with you every other month, but call us if something changes. Because again, every time we come out, your insurance gets billed. And so we don't want to come and do an unnecessary billable visit. But you can always call and we'll come back out. So usually our palliative teams are a nurse and a nurse practitioner who work together. And then our hospice team is that full interdisciplinary team. So you have the physician, the nurse practitioner, the case manager nurse, the social worker, the nursing assistant, chaplain, volunteers. Did I miss anybody?
CNAs.
CNAs. So that's that full team. And yes, so we're really coordinating that care and coming in much more often. You're generally seeing a hospice nurse probably at least 2 times a week, more as symptoms progress and as things start to, get a little bit more intense. Social workers twice a month, I believe.
Typically twice a month.
Yeah, chaplain about once a month.
Could be once a month, could be twice a month, depending. And I think one of the unique things about hospice too is that, we tailor and we cater towards what the family needs. And so we may have, 2 different families. One family, they want us there, almost every day. Someone's in the home providing that support, whether it be medical support, psychosocial support, spiritual support, we do all of those things. So, and then we could have another family that they're like, hey, you know what? We have a lot of folks at church. We got a lot of support. We have neighbors that come by. We're not having any symptoms. We kind of want to live our life. Maybe just come once a week. And they may only get a visit once a week. So it really depends on the family, the person. And again, we kind of have those goals of care conversations, what their needs are, and then we adjust it as needed.
Is that all covered? We had quite a few questions in advance about the cost. Is that something that is all covered by insurance, even if it's we're coming every day or close to every day situation?
Yes, with hospice care, it's all covered under the hospice Medicare benefit.
Right. And that is one of the few benefits in Medicare that is covered at 100%. So there's no out of pocket, there's no deductible, there's no co-pays, there's nothing. So it's covered at 100%, all those visits. And in addition to that, all the medications related to the diagnosis and any comorbidities, and then durable medical equipment. So your hospital beds, over the bed tables, bedside commodes, wheelchairs, you name it. If there's wounds, gel mattresses, like whatever the patient needs, we're focused on comfort. So if it's something that's needed for comfort, then that's what we're going to provide.
And all the care is at the patient's home. It's not a residential.
Okay. We do have hospice houses. Yes.
Yeah, I was gonna say, so home or wherever the patient's home would be, so long-term care facilities, they can, which is nice because it's certainly like an extra layer of care, on top of what they're already receiving. And kind of that personalized, like they're there just for, that resident, that patient, and can kind of help communicate with the family, which is, I think that was really one of the benefits, the greatest benefits that I saw, especially during COVID is, kind of reporting back and letting them know, sometimes it can be difficult, communication wise, with some of the communities, the long-term care communities. So, typically the nurses I would work with would call the family, after every visit or at least every other visit, kind of letting them know, like, what are they seeing? How are things going? Any concerns that they have? So it's kind of an extra set of eyes, which is really nice. And then of course the hospice houses that you just started to mention.
Yep. So we have 6 hospice houses. We have 3 in Mecklenburg County. And so think of them as like hospice hospitals. So it's for those acute patients that are in the home and symptoms are just not managed well. You need more nursing intervention than what we can do with even a visit daily. And so that's where the hospice houses would come into play. It's one of the highest levels of care under the Medicare benefit. And so Medicare says you can go into the hospice house, they'll pay for that. So it's intensive nursing, it's room and board, meals, things like that. And the goal is to bring the patient in, manage the symptoms, get everything calmed down, and then hopefully take them back home. Doesn't always happen that way. A lot of our hospice house patients end up with a terminal stay. But they're a great alternative because if you do end up in a hospice that does not have a hospice house, you may end up in the hospital if those symptoms become unmanageable at home.
What about respite?
Hello. One thing I recently, find out, my wife just got into hospice a month and a half or 2 months ago. The respite care that they provide in Gaston County, I know that's where we are. But now I'm gonna be able to go to the beach to visit with some friends for a few days this weekend, and she's going to Robyn Johnson for 3 or 4 days, up to 5 days, I think it is, per whatever period, month, or I'm not sure exactly what the total amount, but then they're going to let my daughter stay there with her, visit with her, stay with her overnight with her, or whatever, till we can make sure she's comfortable. So really a great benefit there too.
Yes.
Yeah.
Yeah, that's up to 5 nights. And Medicare will pay for it about once a month. I mean, there's no limit, but they start to question it if we do it more than once a month. But we have done emergency respites where it might be twice in a month if just something crazy is going on. But yes, it's just for that. You don't have to be going to the beach to do respite. You can you can go home and take a nap for 2 days. It's exactly that. It's to give the caregiver rest because it's hard to be a caregiver. And
So for respite, then you could be getting hospice at home. And then you just take the patient to the hospice house for a few days and then they bring them back home.
or we do respite in some of our skilled nursing facilities as well. So just depending on bed availability, so we can do it at a skilled nursing facility or in our hospice house.
And that's covered by Medicare.
It's all part of the hospice benefit.
I have a crazy question. My dad was on hospice. This was in a different state almost 5 years ago. But I seem to remember we struggled a lot as a family about, are we ready to do this? And first of all, we were surprised that hospice meant he stays home. We were delighted by the number of people who were suddenly paying attention, not only to him, but to my mother, who was his caregiver. But I seem to remember that somebody at one point said that it was a reversible decision. Is that true here as well?
Yep. So if you elect your hospice but Medicare benefit, and for whatever reason you decide you want to go seek aggressive treatment, you would go into the hospital and do something aggressive, one piece of paper, you revoke your hospice benefit and you're right back to your regular Medicare, and you can go do whatever you need to do. So you would just call us and say, hey, I want to revoke services. Usually one of our social workers comes out, sign a piece of paper, and it's done. And you can come back and forth. So once you revoke, you go do whatever you were going to go do. I mean, we'll have folks that fall and break a hip, they'll revoke, go get their hip pinned, replaced, whatever, and then come right back under care.
Yeah, that was the example we talked about, I think. Okay, thank you.
If you were in hospice, would you still be able to see your doctor at memory movement or not?
That sounds good. I know that was a question that somebody had posed.
So yes. I answer for me. Yes, you can. So do you guys normally stay attending? I
know Dr. Edwards does
Yeah.
a lot of times, so it kind of just depends on the patient family's preference. And
so if Dr. Edwards or any of the folks here do stay attending, then he's very actively involved in the care and you can still continue to see. If he's not attending, you can still come and it would just be billed through us. So either way, that's fine.
Someone asked how home care agencies would work together with hospice. Is there any collaboration there, or does hospice replace the home care?
No, I wouldn't say that we replace home care. Now, I will say it depends what type of home care services. Now, we do have a lot of home care patients that are receiving like private duty caregiving services through community agencies. So maybe the caregiver, the patient might not be sleeping well at night. And so they kind of supplement our services by having someone come in. They might come and help them get a shower every day, or help them, just provide supervision while the caregiver works part-time, whatever that looks like. And so there are agencies that can come in, and whether it be private pay, sometimes folks have long-term care insurance policies. Sometimes if they're a veteran, the VA has services that can come in, PCS. So there's a variety of services that can work concurrently with hospice.
And we'll try to coordinate with them. So we'll say, okay, we don't both need to come and give a bath on Tuesday. So let's coordinate and say, okay, we've got, Monday, Wednesday, Friday, you home care, they'll pay for Tuesday, Thursday, Saturday. So we're not overlapping services because there's no need to pay for services twice. Yeah, absolutely.
in my experience, kind of seeing the way that the CNAs and the nurses work with, private duty caregivers, agency caregivers, they really do try to collaborate so that, they're kind of sharing information, sharing recommendations. So, I guess from my experience, they seem to work together well and kind of complement each other. How about, so I think just some of the things that, you know, we hear when we talk about, you know, hospice care, just to, you know, kind of make sure that everybody has like correct information. So I guess sort of you know, or misperceptions about hospice care. What do you guys hear most often? Like one of the things I would probably say is, you know, we're giving up, which, you know, that was definitely not my experience, but you know, kind of, can you speak to that a little bit?
I think commonly what I hear out talking with our families, you know, and to your point, you know, they feel like, well, we're giving up. We didn't want to give up, but we're giving up. And, you know, I feel like our response, and this is what came out is that hospice to me, it's about life. It's about living. It's about quality of life. What does that look like for somebody? And so what are your priorities? What are the things that you want to do? So we have a lot of those conversations, and that's where kind of our social worker comes in and kind of talks about what are your goals? What are the things that you want to do? How can we support you all as a family in getting through that? You know, and I think it is a perspective adjustment for sure. You know, so we really try to focus our conversations on what is going to bring the most number of, you know, the most life to our days, whatever that looks like, and how can we support through it. I would say, you know, the other myth that I hear a lot is, you know, that we come in and the family might think, well, this is it, you know, hospice is here, this is it.
Start morphine, you're gonna die.
Yeah, start the morphine now. And, you know, we have folks, I mean, I had a patient who was with us for 2 years. I mean, that's not the norm, I'll say that. But, you know, we have many folks that are with us much longer than we ever anticipate. Because what you see on television about hospice, it's not pretty. You know, it's kind of like what you see on TV about social workers, also not pretty. So, you know, that's not what the reality is. And we really come in and it looks so very different than what we see on TV or on any other media. It's really about quality of life, quality of care, and how we can keep folks in their homes where they want to be, for however long, you know, that looks, and it's different for each person. We certainly don't have our own timetable. That's between, you know,
We don't have an expiration date on us somewhere.
no, absolutely not. So,
Well, I mean, there's so many things. I've been here 7 years. I mean, I can think back to so many. We've done weddings, we've done graduations, we've done beach trips. I mean, there's so many different things. So really saying what's important to, you know, when I first got here, we had a cancer patient whose daughter was graduating nursing school. And the mother wasn't going to live to see it. And so we called App State, and they actually sent folks down from App State, and we did a full graduation in that family's home because she wanted her mom to see her graduate. So that's the sort of stuff. It's what's important today, not how many more days am I going to live, but how can I make today the best day possible?
Well, I think the thing that we saw sometimes is that, you know, with this kind of cocoon of support, you know, sometimes patients that were declining and failing would actually kind of plateau. They would do better because they were receiving, you know, hospice support and graduate, you know, from hospice care, you know, because they were actually doing better, you know, with the amount of support that they were receiving. So absolutely. Yeah. Can you guys talk just a little bit, I guess, about what would make somebody eligible for either palliative hospice care?
So I think anyone for palliative care, anyone chronically ill, Parkinson's, cancer, it could be like a prerequisite, maybe a 2 or 3 year prerequisite for hospice. Get the patient under palliative care, have the extra resources for the family members, and then we move to hospice once they're no longer seeking treatment or they have a medical diagnosis of 6 months or less.
And palliative can really help sort of guide that when is the right time for hospice. And so that's why it's nice to have palliative involved, because you have nurse practitioners coming out to the home. And so they can say, okay, here's where we are. You know, this is what hospice would look like. We're not there yet, you know, and so it sort of gives you a good guide of where you are in that disease trajectory.
It's also a lot more gray with, for example, our dementia patients, because there's
Can you talk about that for a minute?
I'll let you speak to that. But yeah, it's you know, with something like cancer, a doctor can much more easily say, here's the timeline. And that's part of, you know, we help skew the average of the hospice patient timeline because it can be so much longer than just 6 months, depending on the patient.
It's so unpredictable.
Yeah, I think, generally, and correct me if I'm wrong, it's been a few years since I've been in hospice, but I think generally, and we talk about what we call the global deterioration scale. So it's kind of a sort of guide of where someone is in the disease process. But typically it's kind of that stage 7 where somebody, has, obviously advanced dementia, if we're talking about dementia specifically. Typically at that point, not ambulating, not getting around well, may start to see more falls. You may start to see weight loss, maybe not eating as well, having difficulty swallowing, more difficulty communicating, and that doesn't necessarily have to be, not verbal, but, if somebody's just kind of parroting like a few words, typically that's obviously not effective communication. Usually, typically loss of bowel or bladder function at that stage. There may be recent hospitalizations, infections, skin breakdown, but I think there have been a few people that we referred that maybe don't meet all of this criteria, but they, in addition to that, they've had some weight loss, that would make them potentially eligible. So kind of looking at the whole picture, it doesn't have to necessarily be hard and fast at stage 7, but kind of looking at the whole picture. Have they had multiple recurrent infections? Have they been in the hospital? Are they losing weight? So those are kind of all the things.
They wouldn't have to stop taking their medication if they're on hospice.
No. No, and I think that's a conversation, obviously, this came up recently. So typically by the time, you're probably referring specifically to donepezil, Momenti.
Yes.
Yeah. Okay. So I don't think that's not a requirement necessarily, but the reality is, most of the time when people get to those advanced stages of dementia, those medications probably are not providing a lot of benefit at that point, because the medicines are not, reversing the disease or curing the disease. The goal is really to slow decline and keep them as functional as possible for as long as possible. So by the time, and there is a limited time frame of efficacy for those medications. So typically by the time we get to that point, that somebody is really at those advanced stages, it's not providing a lot of benefit at that point, and can be providing or causing potentially some side effects, like, weight loss, GI upset. So the burden of those medications outweighs the benefit at that point. But I think it's, it's a conversation with, our team, with the hospice team about, are they still providing benefit? Because if they are, and they're providing some benefit functionally, symptomatically, then obviously we would continue the medications. If they're not, at that point, it would be a conversation about tapering and discontinuing.
And there are some medicines, and I don't know the specific ones of dementia, that are quite expensive. And so sometimes that does become a barrier. If it's a $10,000 a month medication, that's way more than we're even getting reimbursed for all of our care. And so there are some of those, but I just don't know off the top of my head if they're really expensive ones.
Yeah, typically.
There's not a ton that we say no to. Again, we're nonprofit, so that makes a big difference. We are willing to pay for a whole lot more than a lot of the for-profit hospices because we're not giving money back to investors. So.
Yeah, but I think, typically when somebody is enrolled in hospice, they will look at the, the medication list in general, because the reality is every time we go to a new physician, typically, there's another medicine added, and again, if somebody's lost weight, and their blood pressure is dropped because they lost so much weight, they may not need their blood pressure medication anymore. Same thing with cholesterol medication. If somebody's lost, 30 pounds, there's a good chance that they probably don't need that. Or if there's a medicine that they're taking that might be contributing to weight loss, or decreased appetite. So kind of, I think that's a good opportunity to sort of look at the medication list and say, what are of these medications are really providing benefit, comfort, quality of life at this point, and which are not, potentially causing more harm or burden, than benefit.
Yeah, that's what they did with my wife. I weaned her off of some of the ones, Nepozil and so forth. The hospice worked with us to make sure we didn't just cut it off, and because you got to look at the side effects and things and try to figure out what's going on.
Annette, did you have a question? You have your hand raised. There's. Oh, she said, what is VIA? She put it in the chat. What is VIA?
Well, that is my last name, but
He
We
doesn't
were-
own the company. or
we were
anything.
formerly hospice and palliative care of Charlotte region. We're growing so much. We're all the way down in Greenville. And I think just having hospice of Charlotte come out. I mean, we're just expanding so much. We needed a name change. And then we got VIA because we help transfer via
hospice.
hospice, via palliative.
Yeah, and so we're the largest not-for-profit hospice in the Southeast. So we started right here in Charlotte in 1978 in the church basement before there was a Medicare hospice benefit. So it was an all-volunteer organization at the time. We are independent, freestanding, so we work with both hospitals, but we are not owned by any hospitals. So we really make our decisions. Nobody is telling us what we can pay for, what we can't pay for. You know, we make those decisions and we make them solely based on what's in the best interest of the patient and the family.
So that kind of relates to the next question. Can you differentiate who is a nonprofit hospice and who is for-profit? Do the hospitals have?
So the hospitals both have hospice departments, I would say, in them. What I would say is when it's a department of the hospital, it's a department of the hospital. So there's a lot of priorities in the hospital. End of life care is all we do. So we don't deliver babies, we don't replace hips, we don't replace knees, we don't do any of that stuff. We only care for folks in that, say, like 3-year period of end of life. And so I do think that is what makes us experts at it. Technically, the hospitals are not for profit. So in theory, the two hospital system hospices are not for profit, but they don't necessarily operate the way we do. And pretty much everybody else that serves in this county is a for-profit. So, and most of the for-profits are usually owned by private equity firms. So they're owned by bankers in various places. And so again, we make a profit. I don't say that we don't make a profit, but we take that profit and we sink it back into patient care and into, quite frankly, care for our staff. So having good PTO benefits, because being a hospice nurse, being a hospice social worker, it's a hard job. You know, so we want to make sure that we're taking care of our staff, that we're giving them raises appropriately, so they're being compensated for the hard work that they're doing. So we do make a profit, but it goes back into that care as opposed to going to the hospital to their bottom line or going to the investors on Wall Street to make their money. Does that answer your question?
Yeah, and I think it is important, you know, if you can't tell when you're exploring, you know, our particular hospice to ask, you know, whether they're for profit or not for profit, because there is a difference for sure.
Absolutely a difference.
I have another curiosity question. Do you partner with other hospice organizations? Like if a patient is going to take that beach trip or whatever, would there be a hospice at the location that the patient's traveling to or visiting a relative or something that could take over?
What do we call a contract?
Yeah.
And so we'll reach out to them and let them know, hey, we've got one of our patients, they're coming to your area. I don't think we actually execute it unless they need the care, but it's
Right.
sort of like there and standing by and ready. And if something happened while the patient was, say, at the beach, they could call that local hospice would come in and provide care, and then we would pay them for the care.
It's really just more of a safety net.
Yes.
Yeah.
And during hospice, does the same caregivers come out, or does it get switched?
Typically, yeah.
Mhm.
We try to find a good fit for the family. So if there's ever need of a change, we can change it out, but typically, yes.
Consistency.
Consistently,
Nice,
yep.
Yeah.
Same social worker, chaplain, nurses,
Mhm.
volunteers, CNAs. We try to keep it the same.
We do let people go on vacation occasionally.
Yeah.
Short of that.
The other thing that we haven't talked about yet too, which is one of the really nice benefits of hospice in general, is the 24-hour nurse line. So because I was on call a lot for hospice, so you know, took a lot of those calls. But so obviously there is typically a case manager that works, you know, during the day and comes and sees the patient, you know, regularly. But if, you know, after hours, there are nurses that are on call. So there is a nurse line that you could call if, you know, something acute happens, you have a question, you would call the nurse line and they could either triage, you know, the question or concern over the phone with medications that are available in the home, or just kind of talking the caregiver through, you know, whatever the scenario is. If it can't be addressed, over the phone through, that triage line, they will send a nurse out to the home to see the patient. So one of the examples that I think about oftentimes is like if somebody has a fall in the evening, obviously it's traumatic, to have to go to the hospital, especially when it's pretty clear that there isn't, any significant injury. So the nice thing is, a nurse can come out, they can do vital signs, they can do an assessment and make sure that there isn't any significant injury, that the patient would need to be hospitalized or sent to the hospital for. If symptoms change, or if there's an acute change overnight, they can come out and do an assessment. And then there's always a nurse practitioner and physician that are on call 24 hours a day. So again, they would call the nurse practitioner physician and say, hey, this is what's going on. I think we need to change medications, or all sorts of different kind of calls, that we would receive. So it's nice to have that safety net, and that 24-hour help, that because it just seems like a lot of things happen overnight for whatever reason. Things can be just fine, for multiple days straight, and then overnight they change. And or even if somebody's have the bad night and symptoms aren't well managed, a nurse can go out and adjust medication, and hopefully address the symptoms quickly. So that's one of the other really nice benefits of.
Yeah, and our nurses they specifically just take call at night. It's not the same team from the daytime, which I know a lot of other hospices do.
I have another question, not to be too specific about a particular situation that I'm focused on, but like, so as a part of the care team in hospice, if the decision is made to go hospice, and so like one of the things that we do for my mother-in-law to get her a break is that we have caregivers come for a few hours, a couple days a week. Which I think what I heard is you can coordinate that, but is that also something that, is hospice more sort of medical focused as opposed to, so like that, it's not like, there's not a palliative aspect to it like that, where there is if you need to get away for a few days, but not a few hours?
So the respite benefit, but that's respite.
I'm sorry, respite.
Overnight. Yes, there's not like a daytime. So yes, hospice, our CNAs would come, but they would spend about an hour, maybe an hour and 15 minutes. So we don't provide that like maybe 4-hour block to go out and do grocery shopping or something like that. So you would need to subsidize that with some caregivers or something.
And I would say too, we have a pretty robust volunteer program. So we do help a lot of caregivers just so they can go out. I have one she goes to yoga 2 days a week, and that's her escape. And so we had a volunteer who was able to come out for 2 hours, 2 days a week, and that was their schedule. So, and granted, it's a volunteer, so it's not a medical person, but just sometimes someone to sit there and watch TV with someone, or, bring them a drink if they need water or something like that, provide companionship, that sort of thing. We try to do that to kind of help. And again, that kind of goes into those supportive care needs that families have that aren't necessarily medical, but, are just as important all the same.
Question about have you had any experience with lift chairs? And I've gotten into it, I guess, with the hospice that we're associated with Gaston, where the lift chairs, I was trying to get my wife in and out of the bed, the lift chair, and try to get her elevated up so I could move her around. And they said, well, there's some rule about Medicare. It covers 80% of the lifting device, or there's all kinds of technical stuff I got into with it, trying to figure it all out. So, and they said there's a question whether Medicare would cover it because it's not, necessary for them. And you're talking about end of life services, not just comfort and that kind of thing. They were categorizing it.
So I don't know that a lift chair would be considered durable medical equipment. I think that's what falls in it. I think we cover durable medical equipment, and a lift chair would not fall in that category, and that's probably why.
Oh, okay. Because they were talking about one of those Hoya lift things, but that takes 2 people to try to lift somebody up. So
I know a lot of times though, our social workers we have some community resources that may be able to, there are places and families that sometimes will purchase a lift chair, use it for a month or 2 weeks, and then try to offload it. And so sometimes we try to coordinate as a group if we have folks who are trying to sometimes get rid of it and we're like, hey, I know a family over here who could really be in need. I think that's where we try to work together as a team to see what we can help kind of supplement to that, even when we run into those Medicare roadblocks.
I got you. Thanks.
Thank you.
I can't read far enough up there to see if there's any.
Because my husband's in Southminster, okay, skilled nursing. And, you know, like, I just want to try to provide him the best quality of life. So I need to learn more, okay, about coordinating your services, okay, you know, Southminster's services. How would that?
And did you say he's currently under hospice care or no? He's just
No, he's
okay.
not.
Okay. So I mean, that may be a good place to start with palliative. You know, just start with palliative. Let us come in, assess where your husband is today. You know, what does that look like moving forward? And then they've got some great social workers over there that I think if he's not hospice appropriate can help you with, you know, finding some additional resources for him. But yeah, I think palliative would be a great start.
Like we said earlier, palliative care can really be one of the main benefits is the resource for the family and having someone for the family to talk to, a main point of contact to go to with any questions that you may have. You'll have the same nurses coming out and seeing them.
And the nurse visits we do not charge for, so we cannot bill those. So a nurse will come out more often in a skilled nursing facility like that. A nurse is probably there every couple weeks, so she'll come in and check on him, and it's not a billable charge. It's only when our nurse practitioner comes out.
And my experience, and it's been a few years, but it worked in Southminster a lot, and a lot of our patients were cared for there. And I think the hospice team or palliative care team and the staff there work really well together. And I think actually the staff there at the facility really appreciate having the extra support, you know, and resources that palliative care and hospice provide. And they communicate well. I think you know, communicating any changes, any concerns, because it's certainly, you know, not only a resource and support, you know, for a patient, for the family, but also for the staff there too, because it's, you know, an additional, you know, kind of layer of support and resource.
An extra set of eyes in those buildings.
Yeah. Well, and too, if, you know, I think if there, you know, are needs or changes, you know, they like knowing that there's somebody that they can call, you know, that can kind of step in and help them navigate, you know, what's happening. So they definitely seem to work well together. And I think both appreciate, you know, input, you know, from both sides.
So, you know, regardless of what stage he's at, okay, in addition to the dementia, he has a seizure disorder and, you know, things of that nature. So, you know, regardless of the stage, palliative care would be beneficial to begin.
Absolutely.
Okay.
And because he's in the skilled nursing building, we would need an order to come in and see him. That's the only place where we're required to have an order by the physician in the facility. So if you just let the social worker know there that you're interested in having palliative care come in through via Health Partners, they'll send us an order and send us a referral, and then we'll reach out, schedule a time to come.
Are there any other questions that I can't see from?
Do you work on final plans for like funerals, and is that the chaplain usually do that, work with the family, or, you know, the means of disposal of the body, you know, whether it's cremation or, you know, a regular kind of service or whatever?
Yes, absolutely. So whether it be the social worker or chaplain, those are kind of, I'll say whether it's community resources that are needing. I know our social workers have a pretty comprehensive funeral home list. Kind of, we have those conversations about what do people prefer, cremation, burial? Do you have arrangements in mind? And that's one of the things that we certainly try to have those conversations. And our chaplains, we have wonderful chaplains that sometimes they've been asked to actually perform the funeral ceremony. So We definitely encourage having those conversations with our families, and we do have resources to kind of help start those conversations.
Okay.
One of the questions I think that was sent ahead of time, which is sort of related, is just about, kind of finding care for a loved one when they may not be Medicaid eligible. There aren't a lot of financial resources. Obviously, it's something I'm sure, obviously, as social workers, you guys help to guide. Some of the resources are, there are some caregiver grants. So obviously, even, if somebody would be under hospice care, if there are needs, with kind of day-to-day hands-on care beyond what's being received. So, there are some caregiver grants that will help to kind of offset the cost of caregiving in the home. Kind of different or separate from hospice services. There are PACE programs that are comprehensive programs that provide medical care, nutritional services. And those are something that Katie could talk with you about. And then also, I think just reaching out to the local council or area on aging. Sometimes they will have resources as well as far as caregiver support and potential financial assistance with getting caregivers in the home.
We'll say one thing about PACE. So just so everyone's clear, PACE is an insurance at the end of the day. So you're signing up for an insurance, and so they do not have a hospice benefit.
Okay.
So if you sign up for PACE, they don't have a hospice benefit. And so you do not have access to hospice. You have to unenroll in PACE and go back on to traditional Medicare. And sometimes that can be, if it's the 15th and I decide I want to do that, okay, so then I have to give notice on the 30th, and then I have a 30-day waiting period. And so in some cases, there's not enough time for hospice to come in. So that's what the one thing I think that's a little bit misleading about PACE is that you're actually signing up for a health insurance. It's more than just a program. And people don't realize that. And they're like, wait, what do you mean I can't have hospice?
Yeah, that's important to know.
Yes.
Any other questions? Okay.
I have a question. And I had to jump in a few minutes late, so I may have missed this. It sounds like this is specifically for people who are already on Medicaid. And I guess I didn't know, will you be doing another sort of a Q&A about that whole scenario of, all of your finances not falling apart in order to be able to get your loved one into the type of care that they need? Maybe it may not be end of life, but any help on that?
So more long term. Are you talking for someone who's not yet at Medicare age?
No, I think she said
Or-
not end of life.
Not end of life. Okay.
Yeah, like my husband is, he's not on Medicare yet because he is working, but it probably won't be that much longer. But he's not going to be needing those kind of services yet. But I'm thinking ahead, like what do we have to do? How do we approach that? I understand I'm gonna have to see an elder law attorney or something, but basically, is there some kind of, will you be doing any kind of workshop to kind of help us through that?
Well, thank you for the idea. If you have any others, you can always send them to email@mnclt.org, and we're always looking for ideas for these, but that's a great one. I think it would help a lot of people.
And just on the payer source, so while hospice is a Medicare benefit, we do take plenty of patients under care that are under 65 that are on private insurance. And so we are contracted with most private insurance companies. Even if they don't have a Medicare, like a hospice benefit, we can still usually call them and make arrangements. And then we are a not-for-profit, so we take anybody regardless of their ability to pay. So if they have no insurance, their insurance doesn't pay, it doesn't matter. We still provide hospice care, but we do have quite a few patients under 65 that are not Medicare eligible yet. So it's not a barrier.
Have you received requests from long-term care insurance policies about your license or certificate or something like that?
The long-term care
I'm not
insurance.
sure.
In fact, Yeah, the one that I have is we switched over from she was going to a center before she went to hospice, an adult daycare center, which they provided all the documentation back to the long-term health care policy people. But I just got a letter from the other day and said we've asked your hospice for their documents that they wanted from them.
Yeah, I mean, typically most, at least in my experience anyway, the people that I've worked with that have had long-term care insurance have accessed that for private in-home care, or sometimes to move from residential into a skilled nursing or assisted living or family care home sort of situation. I can't recall anyone I've worked with that has used a long-term care policy to cover hospice, but that just might be because it's never popped up with any of my folks.
Well, I'm not using it, I guess, for hospice because I'm not actually paying, anything, but I am using it for people that come in, that help my wife. And so it's more of that, they're concerned, and I'm on a cash benefit, so they're paying me the monthly thing. So I just wondered if you heard of that. Maybe they're trying to coordinate and see something about the quality of that hospice care unit. I don't know.
Well, they probably want to make sure, because there's an eligibility piece to that with long-term care's pays. There's a certain eligibility, and so they probably want to see documentation, which she obviously is, that your wife would be eligible to continue those long-term care benefits.
Oh, okay.
Yeah, that's what I would suspect. Yeah.
All right, thanks.
Lots of good questions.
Yeah.
Love it.
Thank you so much to our friends from Via and Heather and Katie.
Thank you. Thank you for inviting us.
Yeah, thank you to our folks who showed up, and I hope you'll eat some cookies. Thank you again to everyone on Zoom for tuning in, giving us your time and your great questions. I hope this was helpful.